But right now we'll call up Denard Cummings. Denard joins us from Albany. He's the recently appointed director for the newly established Bureau of Social Determinants. For those of you that don't know, New York State created the Bureau just about not even 2 years ago, and it was in response to a lot of the things we've been talking about. When you talk about these things, how do you even define a social factor? Or how do you measure it? Or how do you compare progress? And so there's a little bit of recognition from the state that we have to really functionally organize around these things and not just build frameworks, but how do you value it? How do you build business cases around it? So these are some of the topics that Denard has been working on, and we'll speak to some of these today. So without further ado, join me, let's welcome Denard Cummings.
Well, thank you for that great introduction. I was telling Mark when we were talking on the phone about me coming down that I have not been to the southern tier yet. This is my first time, so you guys are welcoming me to the southern tier in this position. As was mentioned, my name is Denard Cummings. I am the director of the Bureau of Social Determinants of Health. We were established in December of 2017. My primary focus at that point in time was implementing the EBP roadmap requirements as it related to community-based organizations and social determinants of health. So I'll talk a little bit more about that in the presentation, so you'll understand what I'm talking about. I've learned, traveling around the state, that it helps to start up your presentation by explaining some of the acronyms that you all will hear. Like, I work for the state, we live in alphabet soup, I hear them all the time, and they make sense to me when I'm presenting. People are like, what are you talking about? So that you don't get stuck on an acronym, let me give them to you now. I'm going to say CBO, community-based organization. I'm going to say MCO, managed care organization, VBP, value-based payment, and VBP contractor. A VBP contractor would be like an IPA, an ACO, or a large hospital health provider system. So I don't think anything else I say will be confusing, but if there's anything else, write it down. And when we have question and answers, ask me and I'll let you know what they are. All right? So today what we're going to do is we're going to talk about what social determinants of health are. We're going to talk about New York State's VBP roadmap standards and guidelines for social determinants of health and community-based organizations. We're going to share some contracting strategies, and we're going to talk about CBOs in action and social determinants of health in action. Just very quickly, show of hands, how many people have heard a presentation by either myself or a member of my staff prior to today? Okay, that's good. That's good, because it's not a lot of repeats in here. So I don't want you guys, don't fall asleep. And if there's any questions, don't answer them too quickly. So you'll steal my thunder. Okay, so what are social determinants of health and why are they important? Why was I invited to present at today's conference? Good questions, and I'm glad that you asked them. Social determinants of health are the conditions in the environment which people are born, live, learn, work, play, worship, age, that affect a wide range of health functioning and quality of life outcomes and risks. Social determinants of health include a broad array of social and environmental risk factors such as poverty, housing stability, early childhood education, access to primary care, access to healthy food, incarceration, and discrimination. Most social issues can be categorized into 5 key domains: education, economic stability, neighborhood and built environment, health and health care, social and community contacts. Challenges in one or more of these areas can impact an individual's health. This pie chart offers factors that are correlated with health outcomes. So what is the key takeaway? Research has determined that medical care accounts for only 11% of an individual's health outcomes, with the remaining 89% being attributed to social, environmental, and biological factors. So why are social determinants of health interventions important? Addressing social determinants of health can have a significant impact on health outcomes. Social determinant of health interventions can be less costly than traditional medical interventions, and under VBP, VBP contractors aim to realize cost savings while achieving high-quality outcomes. The VBP program design incentivizes VBP contractors to focus on the core underlying drivers of poor health outcomes, the social determinants of health. Across the country, state policymakers are increasingly focused on social determinants of health because of the importance of the influence that they have on health, healthcare outcomes, and Medicaid spending. There is an extensive body of evidence that shows that social determinants of health play a powerful role in shaping health and health outcomes. To stimulate VBP contractors to venture into this crucial domain, VBP contractors in level 2 and 3 arrangements will be required as a statewide standard to implement at least one social determinant of health intervention. So I don't know how many of you all have actually read the VBP roadmap, but within the roadmap there are standards and there are guidelines. So this is a standard. A standard is a requirement. It's not something that we're suggesting that it's done. We're saying this must be done. The guidelines are suggestions, strong suggestions, but suggestions nonetheless. So what this particular standard says is that for contracted entities who are interested in moving to level 2 or 3 arrangements in value-based payment, they must include a social determinant of health intervention. VBP contractors have the flexibility to decide on their own social determinant of health intervention. The intervention should be measurable and able to be tracked and reported to the state. So what this is saying, this is a guideline, and what it's saying is that we're not going to dictate to the arrangement what intervention they must do. The intervention should be data-driven and implemented based on what the data for the arrangement suggests. The VBP contractor must select a social determinant of health intervention that aligns with at least one of 5 domains of social determinants of health, which include education, social and community contacts, health, healthcare, neighborhood, and environment build. So a lot of times when we put up this slide, I want people to understand that these are just the 5 domains, and within each of those domains, any social determinant of health intervention that you probably would think to do is captured within one of those domains. Sometimes people say, well, I do something that's not there. What about my intervention? I'm saying, like, well, you know, these are just examples. Everything that you do that addresses someone's social needs or social disparities will be considered a social determinant of health intervention. So the first step in the evolution of healthcare delivery system in New York State is changing the conversation around the delivery of healthcare services. So fundamentally what we're trying to do by requiring that social determinants of health be addressed is we're trying to change the way that healthcare is delivered in the state. And I was encouraged just listening to all the individuals who spoke prior to me, is that it seems like this region really understands the importance of addressing social determinants of health. So I'm kind of speaking to the choir, but I'm going to say it anyway because it's my job. Okay, so to start the conversation, I'd like to share a case study on Philip. This picture shows a pre-intervention image of Philip and his caseworker. Philip is homeless, food insecure, with chronic comorbid conditions, a history of substance abuse, cognitive limitations, criminal history, and a system of informal social supports. 1 year prior to any intervention, Philip visited the emergency department 160 times. I chose to share this case because it is a clear demonstration of a dysfunctional healthcare delivery system and the example of the consequences associated with not addressing Philip's social determinants of health. Enrolling Philip in a health home to coordinate his care and offering him supportive housing and nutrition intervention allowed him to recognize a reduction in law enforcement interactions, increased medication adherence, and a reduction in emergency room utilization from 160 visits to 20 visits a year following the intervention. How does considering this case begin to change the healthcare delivery conversation? With the next 2 slides, we'll take a close look at 2 types of social determinant of health interventions that have demonstrated significant impacts on the quality of life and health outcomes. Since 2011, The Medicaid Redesign Team Supportive Housing Initiative has invested in various housing interventions to address housing stability for high-cost, high-need Medicaid members. Upon evaluation, a pre-post analysis demonstrated that housing a high-need Medicaid member resulted in a 40% reduction in inpatient days, a 26% reduction in emergency department visits, and a 29% increase in care coordination. This is all very nice, but what's the point? The point is that housing is healthcare. Housing stability improves a participant's health outcomes and quality of life. Another great example of social determinant of health intervention positively impacting health outcomes is offered by God's Love We Deliver. God's Love We Deliver provides medically tailored meals. In doing so, they reduce overall healthcare costs by 28%, reduce overall healthcare costs by 28%, reduce hospitalization by up to 50%, and increase medication adherence by 50%. Nutrition is an inexpensive intervention. As a matter of fact, you can feed someone for half a year for the same cost as 1 day in the hospital. Again, very nice, but what's the point? The point is that food is medicine. The reason why I like to share those examples and present in that way is because my specific focus is engaging community-based organizations and encouraging them to enter into value-based payment arrangements. And in many instances, the community-based organizations, they're very mission-driven, which is great. But at times, they're not able to connect the work that they're doing to the healthcare system and understand, like, where exactly do I fit? And so, for example, I like to use the food example because I was talking to a community-based organization in Long Island, and they were saying, what we do is we just feed hungry people. That's what we do. And I said, well, but you do so much more than that. And like, well, no, if someone comes in and they're hungry, we give them food. I said, well, if someone comes in and they're hungry and they're on a medical regimen that requires them to take the medicine they can't take it on an empty stomach, you're feeding them is allowing them to adhere to their medication regimen. So not only are you giving them food to fill their stomach, but you're allowing them to adhere to the medical intervention that their doctor is trying to prescribe to them. And so when you begin to help the community-based organizations understand the role that they're playing in the overall success of the large health systems, of the managed care organizations, it's like kind of like an eye-opener for many groups. So let's talk about the VBP roadmap requirements for Tier 1 community-based organizations. Starting in January 2018, VBP contractors at Level 2 and 3 arrangements must contract with at least one Tier 1 CBO. This requirement doesn't preclude VBP contractors from including Tier 2 and Tier 3 CBOs in an arrangement to address social determinants of health. I'm going to talk a little bit more about the role of Tier 2 and Tier 3 CBOs, but I want to just repeat that statement. Many times when we're presenting, Tier 2 and Tier 3 CBOs are saying, well, you guys are excluding us in this roadmap. And that couldn't be further from the truth. So I'm going to kind of explain in a few slides how that is not exactly the case. But to clarify all the confusion in the room, what is a Tier 1, 2, and 3 CBO? I know that you guys are wondering, what is a Tier 1, 2, and 3? So a Tier 1 CBO is a nonprofit, non-Medicaid billing, community-based social and human services organization. A Tier 2 CBO is a nonprofit, Medicaid billing non-clinical service provider. This would be a provider of like transportation services or care coordination. And a Tier 3 CBO is a nonprofit Medicaid billing clinical and clinical support service provider. So these individuals will be providing services that were licensed by the Department of Health, the Office of Mental Health, the Office of Persons with Developmental Disabilities, and the Office for Alcoholism and Substance Abuse. So what exactly is the role of the Tier 2 and Tier 3 CBOs in VBP? So within the roadmap, there's a specific requirement that you have to include one Tier 1 CBO. One of the challenges that we've recognized across the state is that many of the Tier 1 CBOs are not ready to enter into VBP arrangements. They don't have the infrastructure to do so. They don't have the bandwidth to actually enter into these arrangements. So what we've been encouraging is that they partner with Tier 2 and Tier 3s. So we've been saying the more the merrier. While Level 2 and 3 arrangements must include at minimum one Tier 1 CBO, A VBP contractor can include more than one CBO, including a Tier 2 or Tier 3. Make a friend. Tier 2 and Tier 3 CBOs may partner with Tier 1 CBOs to help support the implementation of a social determinant of health intervention. VBP contractors are incentivized to include multiple CBOs. By addressing social determinants of health, CBOs can have a larger impact on the overall health of Medicaid members, which may result in more shared savings for a VBP contractor. And then finally, the final two is they align. The Tier 2 and Tier 3 may be a logical partner for specific types of arrangements if the services the CBO provides are aligned with the arrangement of the lead VBP contractor is implementing. And finally, Tier 2 and Tier 3s, because there tends to be more robust organizations, they're able to cover a larger geographic area. So these are reasons why the contract entities, the managed care organizations, and the VBP contractors should be looking to work with the Tier 2 and Tier 3s. We're going to talk a little bit about contracting strategies that work for the definition of VBP next. So let's get there so I can kind of explain to you how it is that a Tier 2 and Tier 3 can actually fit into these arrangements. So let's start with the most simple contracting strategy. We're going to do like 4 different scenarios. So this is scenario A. A CBO may support a VBP arrangement by contracting directly with a managed care organization to support a VBP arrangement. So in this arrangement, the managed care organization contracts directly with the CBO to provide services for the VBP contractors that are in an arrangement. So let me put this into plain English, because you guys are like, what the heck is he talking about? Forest Land Hospital enters into a level 2 total care for general population VBP arrangement with Greenleaf Managed Care Organization. Don't Google these, they don't exist. These are fake names. They don't really exist. Many of the highest emergency department utilizers covered under the arrangement have lack of access to affordable housing. Greenleaf contracts with Hazelcrest Housing CBO to implement a housing intervention for the highest utilizers covered under the Forest Land VBP arrangement. So in this arrangement, I think I'm kind of beating this to death, but the managed care organization can contract directly with the community-based organizations. We've recognized in implementation across the state that this particular arrangement is more challenging in some parts of the state. So in, like, for example, New York City, there are these really large Tier 1 CBOs, and they're able to contract directly with the managed care organization. We recognize in different parts of upstate that's not the case, where there's not a large enough community-based organization that can contract directly with the managed care organization. So let's look at scenario B. So a community-based organization may support a VBP arrangement by contracting directly with the managed care organization to support multiple arrangements. So instead of just dealing with the one healthcare provider, they can be contracted to deal with multiple providers at the same time. And like this would be example, let's say, for example, the managed care organization had a contract with a food bank or someone providing food services, nutrition services. That particular provider could service multiple arrangements with multiple different healthcare providers, with multiple IPAs or ACOs. Scenario 3, the CBO can subcontract with the VBP contractor. So in this scenario, the CBO is not contracting with the managed care organization directly, but rather they're contracting with the hospital to do a certain type of function. And the funding is being filtered through the arrangement between the managed care organization and the contractor to the community-based organization for the services being provided. And then the final scenario kind of addresses the Tier 2 and Tier 3 that we started talking about this. So a multi-tier CBO partner contracts directly with a managed care organization to support a VBP arrangement. So in this scenario, the Tier 2 or Tier 3 can contract directly with the managed care organization or with the VBP contractor and have a subcontract with a Tier 1 CBO. So what I'm getting at by sharing all of these scenarios is that under the definition of the value-based payment roadmap, these strategies work. So if you are Tier 2 and you have a direct contract with the VBP contractor or a managed care organization with a subcontract with a Tier 1, it does count, and that arrangement would satisfy the requirements of the VBP roadmap. Okay, I'm going to move away from that before I put you guys all to sleep. So let's quickly transition to the concept of EBP readiness. So how does a CBO get involved? The first thing they need to do is kind of understand their community needs, know their key partners, know their key community partners, the PPS in their area, the managed care organizations in their area, the large provider systems, and the other CBOs. Understand the local VBP level 2 and 3 arrangements, understand data to determine the SDH intervention that is needed in this particular community, leverage existing resources, the community planning grants. I do believe that an award has been granted upstate for the community planning grants upstate at this point in time. So leverage the services that are being provided through the planning grantees, CBO consortiums and hubs, and develop a value proposition. So what is a value proposition? A value proposition is a promise of value to be delivered. It is the primary reason a prospective VBP contractor or MCO would want to work with a community-based organization. Your proposal must explain how your services will align with and add to the success of the VBP arrangement, so the relevancy of it. The key questions to ask when developing your proposition is, what does the community need and how does this overlap with the MCO membership? What services does our organization provide? Who are the community partners? How much does it cost to do what I do? And how does the service and geographic reach provide value to arrangements in Medicaid populations? So I don't want to rush past these because these are really important points when you're going to, if you're a community-based organization, when you're going to negotiate with a large hospital or managed care organization, these are the things that they're going to want to know. And when you're in the negotiating room, you must be realistic about what it is that you can provide. Don't allow yourself to get trapped into a negotiation and providing services that you don't have the capacity to provide, because you're setting yourself up for failure. So in the context of negotiation, we'll talk a little bit more about that later, but in the context of negotiation, require that the people that you're negotiating with understand your capacity and only agree to things that you can actually do. 1, 2, know the value of what it is that you do. In many instances, community-based organizations are doing God's work, and you apply for a grant and you just make it work. And God bless you for doing that. But in this instance, this is opening a new funding stream to you. Make sure that you're able to quantify what it is that you're doing, so when you're negotiating, you can actually come to the table and say, this is what I need to do what you're asking me to do. So what are VBP contractors looking for? Let's start the discussion on what VBP contractors are looking for. CBOs have to have a strong relationship with local community and understand the root causes of poor health among the populations. This is the true value. Like when CBOs are like saying, where do I fit? This is where you fit. You understand the community that you work in better than a large organization has the capacity to do, because in many instances, when individuals are in need in your community, they're coming to you. So you understand what it is that they need outside of what the data may suggest. You understand the needs of your community. That's your true value. A partnership will provide value and align with the goals and objectives. An intervention can be made that can make a measurable impact on the population. When you're considering the negotiating room, you want to be offering an intervention that can demonstrate success. It's nice to say, we're going to do this thing that's going to make people feel good, but it must be quantifiable. In the context of a negotiation, the contract entities are going to ask you, how can you prove that this works? And you're going to be able to demonstrate that it works, and it does actually generate savings. And then the final intervention should be flexible and can be scaled as savings are recognized. And so this is key. One of the things that we've been telling the community-based organizations is when you enter into these, start small. There's nothing wrong with starting small. If an organization comes to you and say, I need you to serve 1,000 additional people and you can't, you can say, well, what I can do is I can serve 300 additional people. Let me do that for a year, and then I'll prove that it works, and then we can renegotiate in a year from now and say, well, how much additional funding can you invest to help me scale up to the point where I can serve the 1,000 people? That should be a part of the discussion that you're having. So the VBP roadmap establishes standards requiring arrangements to include CBOs. The standard is a means to achieving a larger policy goal and create effective partnerships. So I like to take time talking about this because what everyone needs to understand is that bringing the community-based organizations to the table, we're not bringing a subordinate entity to serve a particular function to the table. We're bringing a partner to the table. That is what the roadmap is doing. It's saying when you come to the table, you're an equal partner, and you need to come to the table and be respected in that way. You are a partner. So let's talk about creating effective partnerships. So, pathway to SDH intervention and implementation. As a plan finds the right SDH partners for a VBP arrangement, it is about connecting the dots. Use data to assess the high Medicaid users and membership needs. Utilize performance provider systems and other community partners to identify impactful interventions, and look at more social factors than just one. Identify an SDH intervention with a larger impact. So when you're considering social deficiencies of an individual, generally if a person has housing instability, they have other social determinants that are lacking as well. So if you are designing an intervention that only addresses one need, it's very possible that your intervention may fail because there's multiple needs that are not being met. So think of designing an intervention, think of something that's more comprehensive. How can I address multiple social determinants, multiple domains in the context of my intervention? So, consider 5 considerations when creating effective partnerships. 1, have all key decision makers at the table. When you are going to a negotiation, make sure that the individuals who can make decisions and have the authority to make decisions are at the table. Utilize clear and concise contracting terms to address that address the term of the contract, the parties, the scope of the project, the geographic location, payment methods, fee structures, and reporting and data. Create measurable milestones for the project. Share data between the plans, VBP contractors, and CBOs. This, I cannot stress the importance of this. Sharing data is key, both ways. A lot of times I've heard, as I cross the state, either the managed care organizations are not sharing the data down, the VBP contractors are not sharing the data down, and then the community-based organizations are holding on to their data. In order to have an effective partnership, you must share your data. If I'm a community-based organization, I cannot adequately target your population if I don't have the data to look for them. If I am a healthcare organization, I cannot recognize the success of your intervention if you're not sharing the data to me. And so sharing data is key to an effective partnership. Meet on a regular basis to check on the progress of the SDH project and modify as needed. So what I want to do at the end of the presentation is just talk about a few interventions that have demonstrated success or demonstrated success as we're considering applications that have come in. So first I want to look at the asthma home visiting model. And the reason why I like to point out this model because the success of it is that it's a collaboration between multiple community-based organizations. So you have an individual who has asthma, there is the clinical care that's provided, this is the medication, the assessment, and the monitoring. Outside of the clinical setting, there is home assessments that are being done. So you'll have a community-based organization who will go into the home and assess for asthma triggers, mold, pests, etc. You will have then another community-based organization that can come in and provide health literacy. So asthma self-management specific to the environmental triggers that have been identified. And then the final part of this particular model is having another organization come in and actually do environmental modifications to address the triggers that have been identified by the first model, by the first community-based organization. What are the successes of this model? Research has shown a systematic review on home-based multi-trigger, multi-component interventions with environmental focus indicates that for every dollar invested for this type of intervention, $5.30 to $14 is returned. So there's a huge return on investment in this particular model, and it's able to achieve that because it's comprehensive. It's hitting the issue from multiple different directions. Experts recommend, based on independent systematic review of scientific literature, that this particular model is more effective than a single tier approach that only focuses on one aspect of the issue. In Michigan, a 2005 pre-post study of 37 asthma network patients showed a 66% reduction in hospital admissions, a 46% reduction in length of inpatient stays, and a 60% reduction in ED utilization. Again, I think that these things become real when you show case studies. Let's consider the Smith family. The Smith family is a family of 4. The son has severe asthma with a history of high medical utilization. The house health hazards include deteriorating windows and lead, high mold dust levels, mouse infestation, high volatility, and no vents. Prior to an intervention, there were 3 inpatient stays by the young boy, and on average, they lasted about a week. Post-intervention, there were 0 inpatient stays. The health impact was a reduction in inpatient stays and a $48,300 healthcare cost savings and enhanced health literacy. Just look at some social determinants of health in action, and I'm close to being done. Like whenever I'm starting to lose my voice, I realize I've been talking too much. So I'm about to be done. So these are social determinants of health in action. According to the American Health Insurance Plan, or AHIP, addressing social determinants of health has led to a 26% decrease in emergency spending. WellCare recognized an additional 10% reduction in healthcare costs, roughly $2,400 in annual savings per person for people who are successfully connected with social services compared to a control group. Montefiore Health System in the Bronx has tackled social determinants of health by investing in medical respite, a move that has cut emergency room visits and unnecessary hospitalization for an annual 300% return on investment. This final slide just shows some of the arrangements that we have actually approved to date. So a lot of times when we're talking, people are saying, well, this isn't gonna work, or this can't be done, we can't do this. These are examples of contracts that we have approved that are currently working across the state. So the first one, I won't talk through all of these, but the first one, for example, is a contract between Air NYC, which is a CBO, and Health First, which is a major managed care organization in New York City. It's a 2-part intervention, and again, this one is an asthma intervention, so that's why I did all the build up to asthma. This is a highly successful arrangement that's currently working very well, and they should be reporting out to us, I'm not gonna say soon, but within the next 6 to 8 months. And then another good one would be the Schenectady City Mission and the Eddy Senior Care. This Empowered Health Plan provides ambassadors to health coach and engage clients in field to assess their needs and provide immediate referrals to community resources, and refer clients to health coaches for additional supports, interventions, help clients navigate and address social determinant of health needs, such as housing, food, transportation, health insurance, and assessing primary care. I like to point out that one because, as I mentioned early, the key to social determinant of health interventions is doing something that is comprehensive. And what they do here is they identify the specific needs of the individual, and they develop individualized SDH interventions for each client. So this is labor intensive, but they're in Schenectady, so it's not probably as many people as you'd get in larger cities, but this is actually a really good arrangement. And with that, I will say thank you and open it for questions for all people who are not asleep at this point in time.
So what we've done is there's some notepads on everybody's table. There's also a CCN person at all of your tables, so you don't have to feel like you're shouting to the front of the room. If you do have any questions, just write them down and we'll bring them up. We see those hands. But there's a few first questions, so we'll get started with a little bit of Q&A right now. Sorry.
All right, so the first question is define clinical service provider. In accordance with the VBP roadmap, a clinical service provider is and I can ask both questions because they're related. So the first question is define clinical service provider, and the second is if a CBO is certified to work with a state office for mental health and OPWDD, is that different than licensed? So, in accordance with the VBP roadmap, a clinical service is any type of service that is licensed by a state agency. So if you're providing a health-related service that is Medicaid billable and you are certified by Department of Health, OASIS, OMH, OPWDD, that is a clinical service because you're licensed to do it. And the question about is certified and licensed the same? Yes. It's basically the state is certifying you and licensing you to provide the service.
Both sides.
Okay. Okay. So this question says, since community health workers are recognized in social determinants of health interventions, when will New York State develop a statewide effective community health worker credential built upon a viable workforce trained and educated with core competencies as generalists or specialists? What I will say about this is there's actually a work group that is particularly working on this. I don't have the specific answer to this question, but I do know that there's a group working on this. Whoever asked this question, if you just meet me afterwards, we can talk a little bit more. I'll give you my card and I can give you an update on what the work group actually has underway. Okay, so the first question is, what CBO infrastructure determines readiness to partners with a Tier 3 organization? I don't know that I fully understand this question. Determines readiness to partners. I don't fully understand. Like this question, I think whoever submitted this question could.
I think the question is how can the CBO connect into a VBP and what makes them ready?
Okay. So a CBO can connect with a VBP arrangement, kind of dealing with the things that I was mentioning. Like if you look at the data within your community, like what type of interventions are needed, and then you consider the services that you provide. What's beginning to happen is like there are networking functions that are being held, and the community-based organizations are meeting with the managed care organizations to share their intervention, and if it's what if the managed care organization or VBP contractor is interested in providing, then what they'll do is they will enter into negotiations to contract for that particular service. In terms of readiness deals with a lot of different things. So readiness can be about the organization's capacity to take on additional clientele, the organization's capacity to collect data and report data, the organization's capacity to finance interventions. Are they fiscally solvent? So there are actually tools out there that a community-based organization can use. And if you want, you can email me at the email here, the sdh@health.ny.gov, and I'll refer you to a free tool that will actually help you to determine if your organization is actually VBP ready. But it just simply means that you have the infrastructure to be successful in a new environment where you're actually being paid for the services that you're providing and moving out of this grant universe. In terms of how people are managing data sharing, many of the arrangements that we have seen and approved, there are data sharing agreements. So this is a very good question in terms of if you have an individual who under HIPAA should not be receiving PHI, are you putting yourself at risk by sharing this data? You can enter into a data sharing agreement or what is called a BDA, looking at my state colleagues, I think it's a BDA, yeah, and which would allow you to actually share that information between yourselves and the community-based organizations that you're working with. Aggregation of information. I think that responds to that. I was given another question. I think I lost it just that quickly. No. Thank you. You guys are quick. Okay. This question is, rural New York has small numbers of people spread across large geographic areas. With VBP contracting being numbers driven, how will New York State Department of Health ensure that rural populations and CBOs are well served in this VBP transition? I'm going to give a very generic answer to this question. And the reason why is we're actually looking to address this at the Department of Health, and we're currently working on a procurement. It's in its final stages of approval. And if I go too deeply into it, you guys will all be disqualified from applying for it. So the state understands that this is an issue, and we are working on building and on helping regions to build structures that will allow them to do this. And that's about as far as I can go without disqualifying you all from the procurement. Okay. As more CBOs get involved in VBP arrangements statewide, are changes planned to the traditional state funding streams that have supported these CBOs? No. That's an easy one. I love that question. The answer is no. Like, there will still be grants. State agencies will still continue to provide grants, including the Department of Health. What this does is it just opens up another funding. It opens an additional funding stream that will provide a little bit more stability in terms of budgeting for your activity. So this is not to get rid of grants at all. This is just opening up a new funding stream. If CBOs have multiple service lines, some of which bill Medicaid, many others do not, why can't the specific service line contracted in VBP determine the tier status? The way that we determine the tier of a community-based organization has to do with the tax ID. So if with a community-based organization, the Medicaid billable services are captured under a separate tax ID, then the non-Medicaid billing component of the organization can be considered a tier 1. But if there's only one tax ID, then unfortunately you are considered a tier 2 or tier 3. But in accordance to what I presented, that's not necessarily a bad thing. You're not excluded from any arrangements. We've seen across the state as the healthcare, managed care organizations and health delivery systems have really begun to take seriously addressing social determinants of health. They're working with multiple CBOs, including tier 2s and tier 3. So you're not being excluded if that's the fear. And if anyone has concerns about that, by all means, again, send me an email to this, and we can give you some resources that we've shared with other regions that were concerned about that. And I believe I have like a lot of papers up here, but I believe that I've answered all the questions, I think.
Mr. Cummings, how about a copy of that PowerPoint?
Oh, certainly. I have that. I think Care Compass will be releasing the PowerPoint. Any other questions? So I've told you everything that you need to know, and you can call the Medicaid director and say, he was great. Now I know everything that I need to know about VBP. Okay, if there's no other questions, thank you guys very much.